talk about the enteropathic arthritis. Now, enteropathic arthritis is the arthritis which is usually associated with inflammatory bowel disease and spondyloarthritis. So, in this, we have a patient with a diagnosed or suspicion of an inflammatory bowel disease. Now, because of the inflammatory bowel disease or IBD, they can be joint pain. Now, with joint pain and inflammatory bowel disease, patient can even present with spine. Now, in simple terms, enteropathic arthritis is a condition of spondyloarthritis where we have spondyloarthritis in conjunction with some kind of intestinal disorder, which in this case is the inflammatory bowel disease. And inflammatory bowel disease usually comes in two types, either ulcerative colitis or the Crohn's disease. So this is the enteropathic arthritis. Now, if the patient is suffering from inflammatory bowel disease, and we know that in patients who are suffering from the IBD, they have about 5 to 10% chance of developing ankylosing spondylitis. So they are prone to developing spondyloarthritis. So because of this, if they develop ulcerative colitis or Crohn's disease, which is found in about 70% of all patients with enteropathic spondyloarthritis, we can have the genetic predisposition, that is the HLA-P27. Now that comes in about 70% of all patients. So it is usually that the patients have about 5 to 10% susceptibility to ankylosing spondylitis when they're suffering from IBD. Now IBD can be both ulcerative colitis of Crohn's disease, and because there's already a genetic predisposition because of the presence of HLA-B27, this increases both the chances of the disease and the epidemiology, that is the distribution among the population. Now let's talk about its pathology and pathogenesis. Now as for the pathology, it can be very much like acute bacterial enteritis. It can be like an acute one, it can be like chronic bacterial enteritis. If it is acute, it will mimic the acute enterial bacteritis along with the normal disruption of architecture. There will be the normal architecture will be preserved. There will not be much destruction of it, and only neutrophils will be recruited at that site. But if the pathology is of chronic type, what will happen that there will be widespread inflammation, widespread disruption of the endothelial layer, mimicking the signs and symptoms of Crohn's disease, along with the disruption of both structure of the both villi and the crypts, along with epithoid lesions, and among other things. So pathology can be either acute or chronic bacterial enteritis. And this pathology can be due to certain pathogenesis, and this pathogenesis is due to two reasons. The first one being that there is genetic predisposition. Now this genetic predisposition comes from HLA-B27. Now HLA-B27 is common among all of the spondyloarthritis, and we have talked about it much in the other slides and in the other sections. Next, we have the microbial agents. Now, there are certain microbial agents such as Salmonella or Shigella that can give rise to inflammation in the gut, especially the colonic area. Now, whenever that happens, this inflammation can give rise to a variety of symptoms. Now, if only the colon is involved or inflamed, then what we have is that because of the microbial agents circulating in the blood, we have increased amount of circulating immune complexes. Like we already discussed, that these immune complexes are formed of the antigen presenting cell bound via an MHC with a T cell. Now, because of these circulating immune complexes, there's a cascade of events, and these cascade of events lead to the synovitis, that is the inflammation of the joint. Now, because one of these cascades is that those T cells, which are part of these circulating immune complexes, they clone themselves, they convert themselves into T cells and B cells. T cells turn into cytotoxic, while the B cells turn into antibody secreting cells. All of this results in increased inflammation and increased site of destruction at the synovium. Now, because of the inflammation at this area, at the cut, the colonic area, we can have increased permeability. Now, because of the increased permeability, the patient usually suffer from both constipation, among other symptoms. There is increased infiltration of both B and T lymphocytes, as I discussed earlier, and there's increased amount of macrophaging circulating and proliferating at that area. And the macrophages that usually are associated with the enteropathic spondyloarthritis is usually of the CD163 nature. Now, because of all of these cells infiltrating the area, because of the permeability and because of the already immune complexes circulating the body, we have a kind of a homing mechanism. And this homing mechanism results in the proliferation and recruitment of cells to the synovium. And when they reach the synovium, they start the inflammation and the destructive process. Now, let's talk about the clinical features. The clinical features of enteropathic spondyloarthritis is that there is always an antecedent bacterial enteritis, that the patient will always have some kind of gastroenteritic disease. It can be due to some kind of virus, some kind of amoeba, or some kind of bacteria. But there will always be a history of a preceding infection. Then we have history or even the presence of dactylitis. The patient have the inflammation of the fingers. Then the enthesitis, that is the inflammation of the point where the ligaments and the tendons join the bone. We have uveitis, that is the inflammation of the uvea, the area between the iris and the ciliary body. It is usually of the anterior uveitis type. Then we have finger clubbing. Now, finger clubbing is very characteristic of enteropathic and inflammatory bowel disease. Then we have pyoderma, that is, there is blistering and pustule formation on the skin. We have erythema nodosum. Erythema nodosum refers to the formation of small nodules which are found in clusters along with erythema or rash on the body. Now, these clinical features usually along with the bacterial enteritis present the picture of an enteropathic spondyloarthritis. Now, as for the laboratory and radiographic finding in these patients, we have the joint fluid cytology, and that always comes inflammatory because it is an inflammatory or a pro-inflammatory disease. We have changes in both the axial skeleton and the peripheral skeleton. We have the formation of the HLA-B27, which we have discussed in detail in the other sections. We have the erosions in the metatarsopharyngeal joints, that there is penciling or the barreling of the pharyngeal joints and the phalanges themselves in the feet near the tarsals. And we have sometimes even isolated destructive hip disease. Now, this isolated destructive hip disease is a very uncommon disorder but is usually present with this disease. Next, there is the differential diagnosis. Now, as for the differential diagnosis, we usually get symptomology of both the diarrhea and arthritis coexisting. We get a typical picture of a spectrum of different diseases from common to rare. Now, on the common end, we have the enteropathic arthritis or the inflammatory bowel disease. We have the celiac disease, we have the blind loop syndromes, and on the rare spectrum, we have the Whipple's disease. Now, as for the treatment, the only treatment that works better in enteropathic spondyloarthritis is the anti-TNF alpha treatment, and they can include the infliximab, the adalimumab, and the certolizumab pegol monoclonal antibodies. Now, the first two are monoclonal antibodies, while the last one is the humanized monoclonal antibody. The other treatment options which are available to us is we can use sulfasalazine, we can use systemic glucocorticoids, and we can use immunosuppressive drugs such as methotrexate. Now, the application of sulfasalazine, glucocorticoids, and immunosuppressive drugs depends upon the condition of the patient. If the patient has severe morbidity in its condition, the use of these drugs is justified, but otherwise they are not used, and there is very little evidence that they have some kind of benefit in the progression of the normal course of the disease. They are only used as a last resort in severe form of the disease.